morning, everybody. Good morning. Good morning. I really do not lecture well with a mask on, so I hope you don't mind if I don't have mine on, and I promise I'll segregate myself from you. So, gosh, I'm really excited to be here. I haven't met you yet. Usually I meet y'all in the spring, and I haven't because guess what? I got to retire in January. Woohoo! So I wasn't here to teach in the spring, and you had the amazing, awesome Dr. Bugbee teach you endocrinology, but he had to take over my incredibly difficult lectures I lecture a lot, or used to. So I'm doing pharmacology for you this year, and I'm really excited about that. So I'm Cindy Ward. I'm an internist, and I was here for years and years and years. And again, got to retire. I love endocrinology. I still do some clinical stuff and some lecturing, but it's awfully nice to have a little bit of extra time to do other stuff. So my job today, so I have you for, I think, 5 or 6 hours in here, and we're going to talk about the most important endocrine drugs that I can teach you about. And what I will try to do is what Dr. Ostell tries to do with dermatology. I know being second years, this is all, I'm sure most of you have no reference point for a lot of these drugs. I will try to do that for you a little bit so that it doesn't seem like we're just telling you about drugs that you have no idea about anything about. So I will try to do that a little bit for you, but I also try to emphasize for you what are the drugs that you really do need to know in this pharmacology class and why you need to know them and exactly what you need to know about them, which might not be, like their pharmacological structure or anything like that. Okay, so we're going to start off today talking about adrenolitics and mineralocorticoids. Oh, the other disclaimer I wanted to make is I'm a small animal practitioner. I feel very comfortable talking to you about cats and dogs' diseases and some endocrine diseases in large animals and exotics. I'm not an exotics practitioner, nor if I had a horse and it got sick, I would have to bring it into the University of Georgia because it would be out of my realm of expertise. So I will do my best, but the nuances of cases that you have, I will do my best to answer questions if you have them. But we may have to refer to somebody who knows a little bit more about those species if I can't answer the question. Okay, so having said that, I'm going to start. This is my cat, Steve. This is Steve. Steve is passed out on my husband's lap, who's also passed out watching TV, and this is what they do every night. And I wanted to introduce you to Steve because he's been a beloved family member for 20 years. He's 20 years old. He's got hyperthyroidism. He's got chronic kidney disease. And he's also anemic. He's actually on an experimental drug now. It's a gene therapy for feline erythropoietin. And he's doing really great, but I want to show you a picture of him. He used to be a blood donor here in his younger days. Okay, so what are the goals for the lecture? I'm hoping to give you a little bit of context for these drugs. I promise it'll just be a tiny little bit of physiology that we go through. I know that Dr. Bugbee taught you well about endocrine physiology, but I'm just going to tell you the important part that we have to think about for these lectures. We'll talk a little bit about the diseases that we're going to be focusing the drugs that I'm going to present to you on, which is hyperadrenocorticism and hypoadrenocorticism. And then we're going to talk about some of the adrenolitic drugs. Trilostane or Veterol, which any small animal practitioner is going to have to know well. Pergolide, which is something that we use in horses to treat Cushing's disease. Mitotane or Lysodrin. I want you to know it's out there. I want you to know how it works. You are probably not going to use it very much. It would be something you would use in a cushingoid dog or a dog with hyperadrenocorticism. Then we're going to talk about mineralocorticoids. We're going to talk about desoxycorticoid, blah, 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 DOCP, okay? Which is a synthetic mineralocorticoid that we're going to use to treat Addison's disease in dogs and cats if you have one. They're not very common, but we see them periodically. And then fludrocortisone, which I want you to know about, but you probably will never use. Okay. Part of the problem with teaching is that the little quiz that you guys have to take in your 3rd or 4th year, the NAVLE, is, I know, it's a horrible test, is a little bit outdated. And so I want to make sure that you know, like for instance, fludrocortisone is probably a drug you will never use because DOCP has taken over the market. But I'm always worried they're going to put a question about that on there. So again, something you need to know about. All right, so I'm going to remind you about the adrenal gland. It is such a cool endocrine organ. It's just such an efficient way to make hormones. Basically what happens is that you have cholesterol as kind of your backbone hormone, and depending on where you end up, your cholesterol precursor ends up in these different areas of the adrenal gland. That's going to determine what enzymes you see and what your final hormonal product is. So it's very efficient because you really only need one precursor. The other thing is too, as I always remind myself about this too, is that there's a gazillion ways that you can make just about any hormone out of the adrenal gland, which is why adrenal tumors produce all different kinds of hormones that we wouldn't expect. But anyway, remember that there are 3 layers in the cortex. The medulla is going to actually secrete your catecholamines, and we're not going to be focused on that today at all. But the cortex then has these 3 layers that again secrete different hormones depending on what layer you end up in. The other thing I'm going to remind you about is, because every endocrinologist has to talk about an endocrine axis, and this is the hypothalamic adrenal axis, and hypothalamic pituitary adrenal axis, or the HPA axis as we call it. This ends up being important. You're going to see this a lot when we talk about all these adrenal gland diseases in dogs and cats, and also in horses as well, and also in ferrets, because it is very important, the interplay with how these hormones are secreted and also the negative feedbacks. We use this a lot in our testing modalities, especially in small animals. So just to remind you, the hypothalamus is going to secrete CRH, the cortisol releasing hormone, which is going to go to the anterior pituitary and cause ACTH release, and that's going to cause cortisol release from the adrenal glands. Every endocrine axis, the most powerful part of that is going to be your negative feedback, and so the cortisol comes here, negatively feeds back on your anterior pituitary and your hypothalamus to shut the system off. That's how you want it to be. So as an endocrinologist, the most important tool you have for testing is trying to turn this axis off. Again, not focused on that in this course. You'll be talking about that a lot more next semester in polysystemic, where you're going to have endocrine diseases, and I think Dr. Bugby's still continuing the endocrine elective. Okay, so the other thing that we have to think about when we're thinking about drugs that we're using is what they do, because you have to be able to predict what they're going to do to fix your disease state, as well as tell the owners what side effects may be. So actions of the adrenal hormones, mineralocorticoids are a little bit easier because they don't have as many as glucocorticoids do. So the basic mineralocorticoid produced by the adrenal cortex in animals is aldosterone. And basically it helps your kidney do its job. So you reabsorb sodium and you get rid of potassium, okay? So you need aldosterone to help you do that. That's a normal function of a kidney. So can you tell me what you think would happen if you didn't have enough aldosterone? What's your sodium going to be, high or low? Low, and your potassium is going to be high because aldosterone is helping your kidney do what it needs to do, okay? So it, helps it do its job. Glucocorticoids are the other major hormone that's secreted by the adrenal cortex that we worry about, and these have a million effects all over the body. These are good, and I have a whole separate lecture on glucocorticoids because this is going to be probably the most common drug class that anybody uses. Human physicians, veterinarians, everybody uses a ton of glucocorticoids because they have such beneficial effects on our health. So just remember that it works everywhere. So the diseases in which you're going to either have a lot of glucocorticoids, like hyperadrenocorticism, or not have enough, like hypoadrenocorticism, are going to have a lot of effects. You're going to see a lot of clinical signs because these hormones affect a lot of different things in the body. Okay, just let me, again, this is not a disease-focused class, but I want to tell you why we're concerned about these at all, why you need to know about this kind of stuff. So hyperadrenocorticism, or Cushing's disease, is really, really common in dogs. Okay, this is a dog here. He has a pathognomonic skin condition. I don't know if Dr. Ostel is going to talk about this in Durham. She probably will at some point. But it's pathognomonic really for hyperadrenocorticism or Cushing's disease, and it's called calcinosis cutis, when you get calcium deposits in the skin. I have this really cool picture of a dog we saw last year. I'm going to bring it in so you can see. But like if you palpate that, this is all broken out, but if you like felt it, it would be really hard and crunchy. It's really gross. Ferrets get hyperadrenocorticism. This is fairly common in ferrets, and usually they come in hairless like this. We see it in cats. We're recognizing it more commonly in cats. And they usually present with a skin fragility type syndrome, where their skin is very fragile, and it'll, like, you try to get a blood sample from it and it will rip. Boy, did you guys, I was sitting here for that lecture, did you guys feel sorry for that poor dog that had the horrible vasculitis? Like, I don't even know how you get a catheter in a dog like that. Oh, that was awful. You'd have to do like an interosseous catheter or something. But anyway, all right. But these cats can get really nasty skin infections. And then horses can get cushingoid too. They tend to grow a lot of hair, and they have excess hoof growth, and then they can get sort of pot-bellied appearance. All right. This is common. For a small animal practitioner, I just lectured at Western Veterinary Conference. I did a lecture on Cushing's disease, and it's always packed because this is a disease people see all the time in small animal practice. All right, there are two forms that you can get. The most common is pituitary dependent, and you're going to have a tumor in your pituitary gland. It's going to oversecrete ACTH, and remember our axis says, oh, if you secrete ACTH, you're going to have a lot of cortisol. So a lot of cortisol is secreted because of that tumor. The tumors are benign. They rarely cause any problem unless they're space occupying. So they can cause neurologic effects. About 15% can end up having some neurologic effects from a macroadenoma, but for the most part, they're little. They just secrete a lot of ACTH. So in dogs, 85% of them are pituitary. In horses, they're all pituitary. And in cats, about 50% of them are pituitary. Okay, so again, this is what happens here. You have an excess of ACTH from this little adenoma here, and it causes cortisol release. We wouldn't even care if the animals had it, except that we see the signs of an increase in ACTH or ACTH excess. You can also get adrenal gland tumors themselves, and they overproduce cortisol or other hormones, and that's a whole nother rat's nest to get into. The atypical Cushing's disease is a rat's nest that you don't need to know about at this point in your life. But we see this in dogs about 15% of the time, in cats about 50% of the time, and this is the thing that ferrets get. So horses get pituitary dependent, ferrets get adrenal dependent, and cats and dogs get both. So what happens here is you have this big fat tumor here, and it just overproduces cortisol. But as you remember with the adrenal cortex, and remember it's the different layers have different enzymes, you can imagine that you can see just about any hormone being produced, and there's stuff in the literature, periodic or sporadic case reports about all different kinds of hormones that get secreted by adrenal gland tumors. Okay, so let's talk about how we're going to fix this disease. And again, this is a disease that you are going to see. Yes?
So going back to like either of the two diagrams that are showing like the one that was just on there.
Oops, I went the wrong way. Yeah.
So like the increased cortisol, like I know we see this is awful, but the negative feedback, why does the increased cortisol not further increase the negative feedback then?
Oh, it does. So for instance, if you measure, so in this case, if you measure your ACTH levels here, they're really low. But the thing is that this adrenal tumor doesn't care. It's autonomous now. So it says, you know what, I don't really care whether I see ACTH or not. I'm just going to secrete cortisol. And in the other example, that's what happens here. So your cortisol levels are really high here, and they should, and they're turning off CRH, like you don't have any CRH. But you have this adenoma here, and it just says, you know what, I don't really care about any sort of normal feedback mechanisms. I'm just going to keep secreting. So good question, I didn't explain that. Okay. So adrenolitics drugs, again, are drugs that you're going to be using. The main one that I want you to know about is Veterol, and also Prasin, which you're going to be using in horses, which is Pergolide. Lysodren, I want you to know, is there, but you're not going to use it very much. All right, so let's start off with trilostane. I want to introduce you to a concept that I think is going to make you much more aware as a clinician when you practice. Trilostane is the generic name for Veterol. When trilostane first came on the market, I don't know, like 20 years ago, we all tried it and we were scared of it because you're dealing with an adrenolitics agent, so you can imagine there's a lot of side effects to that. If you overtreat, if you wipe out the adrenal glands. And this drug was so variable that I was like, well, this is a crappy drug. You know, I got the stable cushingoid animal, I've put it on, all of a sudden it like goes Addisonian, like what in the world's going on? Well, it's because it was compounded. And what I want to say to you is, I love compounding pharmacies, they're great, but they are not regulated at all by the FDA. This is one instance where using a compounding pharmacy can get you into trouble. So what I would like to recommend to you is use the Veterol, the manufactured form. It's manufactured consistently and it's stable. And you're dealing with adrenal gland diseases, you don't want to use the compounded form. Anyway, having said that, I need to have you guys memorize this for the test, just kidding. This is where trilostane works, okay? It blocks right here. And so as you can see, it's going to block most of the endpoints of what your adrenal cortex is going to make. So it can block, it's going to preferentially work on this pathway. So absolutely can it block aldosterone or mineralocorticoids? It can, but only at really high doses or only in some animals. For the most part, it's going to work here, and we don't really worry about our sex steroids in our companion small animals, because actually if they're cushingoid, you don't want to breed them anyway, and we're not really worried about that. So nobody has really looked at how much these are affected, but this is the main pathway that gets affected in these animals. All right, so don't use the compounded form. You need to use Veterol, and it is made by DECRA, okay? I will tell you that the capsules are, I'm sure DECRA would like to produce this in any other way that they could besides having these capsules. I will tell you, having a cushingoid animal myself years ago and being the cheap person that I am, I said, oh, I'll just buy the huge capsules and I'll cut them in half because that'll be cheaper, right? Yeah, you can't cut them, trust me. So don't think you're going to go out there and cut these capsules up. I even got the scalpel, and yeah, it doesn't work. So they are expensive, but unfortunately they do have a range of sizes, which is helpful for you. This is a dose for you. I do not expect you to memorize doses. The only dose that I'm going to have you memorize is, and I will tell you what it's going to be, is your glucocorticoid doses to treat different diseases, which I was going to say I'll ask you in every test after this year, which I won't because I won't be giving you tests after this year, but it's something that you need to know to be a good clinician, that there are different doses. But otherwise, doses, in my opinion, that's why God made formularies, and so you can look them up. So the dose for trilostane is 1.5 to 3 mg per kg twice a day. I like to start at a lower dose twice a day because it's more efficacious. The product insert for Veterol used to say, I think it says once a day now, and I think they recommend this dose, but once a day. So I would go more towards the 1 mg per kg or 1.5 mg per kg twice a day to start with in these guys. The other nice thing about this drug is it's also FDA approved. Okay, what are side effects? All right, you can absolutely wipe out the adrenal glands. You can absolutely make a permanent Addisonian out of these guys. That has happened. You can also have a rare idiosyncratic reaction of the adrenal glands where you get adrenal gland necrosis, which is also very rare. So it is not a reason not to use these drugs, but you need to be careful with them. And the other caveat I'll say is that owners like to, and I'm a cheap owner too, like to spend the least amount of money as possible. So there are many people that will say, hey, can't we just treat my dog or my cat, or, well, yeah, or my cat and not test them if that's what you think it is. Do not do that, because if you wipe out the adrenal glands in these guys, you can kill them, and you don't want to do that. So you can make a full-blown Addisonian, meaning hypoadrenocorticism. You can knock out their glucocorticoids. You can knock out their glucocorticoids and their aldosterone, because, as I said before, remember that this pathway, although it preferentially works here to block this, it can also block this as well. And you can do this even if they're on a normal dose. So it's something that you need to watch for. And again, you can get an idiosyncratic adrenal necrosis reaction, which I've seen like 2 in my entire practice career, so it's not really common. All right, how do we monitor this drug? So things that I do when I'm using a drug like this is it's a little bit dangerous to use, and you're going to want to go on clinical signs. One of the common clinical signs that dogs have, especially when they're cushingoid, is that they drink a lot of water. So one of the things that you can have an owner do is measure water intake, and when it starts to go down, you'll know the drug is actually working. My things for the owners are, they start this drug when they're going to be around, not when they're traveling and not when they're working a gazillion hours a week. You just want to make sure the dog's okay. You're going to start on a low dose, you're going to give it twice a day, and the owners are going to kind of be around. And if there's going to be a problem where the dog gets like it stops eating, or it vomits, or it's a little lethargic, you're going to have those owners bring that dog in right away. You're going to see how it's doing, and you're going to catch it early. And with those caveats, it is a very safe drug to use. You want to monitor these guys 14 days after the beginning. Ideally, you want to do an ACTH stim test, where you're going to, basically the question that you're asking, and I don't know if I put this in here or not. Whoops, yeah, okay. You're going to want to do an ACTH stim test. And basically the question that you're asking is, if I give an overabundance of ACTH here, what am I going to get out of the adrenal glands? And many of you are thinking, well, they're already hypertrophied, we know that, or because they're already ramped up from, being stimulated by, all this ACTH they're already seeing, right? Well, the thing is, in a animal that's been treated with Veterol, you've actually blocked those pathways. And so when you stimulate them, what you want to do is see how much baseline material is left. So how much can I get out of these adrenal glands when I stimulate them? Okay, so what you'd like to do, you want to do it 4 to 6 hours after the trilostane is given, and your cortisols, we usually just measure cortisols, and you want those, you would like to have in the normal range. The other thing is, what happens if the owner says, you know what, I'm not paying for that. I am not going to pay for doing an ACTH stim test. There's a new protocol out where you can just look at pre-treatment cortisol, and they say 3-hour post-treatment, but honestly, you don't really have to do that. You can look at pre-treatment cortisol, and I know that Dr. Bugbee will talk about this when we go through dealing with cushingoid animals when you have this in your endocrine classes next semester. But there is a cheaper way to do it. You should never not treat an animal because the owners can't afford monitoring. Okay. So how are we going to monitor what happens with your mineralocorticoids? What can we do about that? Well, you can measure sodium-potassium ratio. How cool is that? So, because it's so cheap and it's so easy to do. You just get a blood sample and you're done, rather than all this ACTH stim tests and everything. So you can do that to measure your sodium-potassium. Normally, we don't do that. If we do a stim test, that's usually all we do. And we don't worry about measuring a sodium-potassium ratio, but it absolutely is something that you can do if you are concerned that maybe you've overtreated the animal with trilostane and you might have wiped out his mineralocorticoids. We do know that trilostane does block aldosterone, so it does do that. And that was actually work that was done here. So the potassiums can rise a little bit on these guys because aldosterone is blocked, but as long as they're under 6, the animals are usually fine. Okay. The other really cool thing is you can use it in cats. We didn't used to have a treatment that was used for use in cats. So it used to be very difficult to treat a cushingoid cat. They respond really nicely to trilostane, and usually we start them at 10 milligrams twice a day. Okay, so you've got trilostane. So you've got hyperadrenocorticism, you're over-secreting cortisol, causing a lot of havoc in the body, skin problems, drinking a lot, urinating a lot, surface infections. I mean, Cushing, they get pot-bellied, they aren't as active because they have muscle wasting. Lots and lots of clinical signs for a cushingoid animal. You want to make them feel better, and we have this great drug that can do it. Trilostane is easy to use. It's reasonably safe in that if you withdraw it, the effects go away, and you give it twice a day. You monitor every 14 days and then every couple months after that when they're stable. All right. There are rare animals that do not respond to trilostane. It just doesn't work in them. And there is another drug that's out there, and I actually grew up with mitotane or Lysodrine because that's all that was available when I first started practicing, and it works great. Issues with it now are that it's becoming harder and harder to find, although you can still get it, it's becoming harder and harder to find. This is a drug that's actually a DDT derivative, and it kills adrenocortical cells. And it is it targets the cells in the layers, the fasciculata and the reticularis layers, because those are the ones that make cortisol. So this was found in people that were exposed to DDT, that their cortisol levels would go down. And then it was found it actually kills those cells. So mitotane, again, is going to go after the cortisol-producing cells. There is an induction phase and a maintenance phase, which, again, you don't really need to know about unless you're ever going to use this drug, which you may or may never use this in your lifetime. But I want you to know it's out there if you have an animal that fails trilostane. So it comes in a 500 milligram tablet size. It's got an induction and a maintenance phase, and it's a little more irreversible than trilostane because you're going to kill those cells. Side effects are, you can cause a total cortisol and mineralocorticoid dependent Addisonian, or you can just cause a cortisol dependent Addisonian. The other thing with Lysodrine is rarely it can be liver toxic, which means you have to discontinue it. Okay, we do a stim test for these guys after monitoring them, and we always run a liver panel. The other thing I forgot to say, and this is really true for any kind of an endocrine disease that you're treating, our goals aren't to make the perfect numbers. Our goals are to make the perfect pet. So you always believe the animal first. And if the animal's doing great at home and maybe a stim test doesn't look so great, you're probably going to leave your meds where they are because you don't want to mess with something that's good. And that's true with any endocrine disease, diabetes, Addison's, whatever you have. We're going for clinical cures, not number cures. All right. Don't use mitotane in cats or ferrets because it will happily kill them. And you wouldn't use it in a horse because it's like, you couldn't even afford to do it. Okay. The other drug that we have, there are two other drugs out there that we have to treat Cushing's disease or hyperadrenocorticism. One is Pergolide. It is a dopamine receptor agonist. You're like, what? How does that work? And it's used to treat Parkinson's disease in people. And it works because horses actually get tumors in the pars intermedia. And dopamine actually causes an overall decrease in the activity in the pars intermedia, even though it's a dopamine agonist. So it will actually cause pars intermedia shut down. And that's where the tumors are. So you can shut that area down in a horse and then control that pituitary tumor so it doesn't oversecrete ACTH. So the pars intermedia is under dopamine control, and the POMC is made there. So it's an agonist, and it ends up reducing the pars intermedia activity and you're like, wait a minute, how does that work? And that's because it's an agonist, and we'll talk about this with Lupron as well, in that it's going to overstimulate that and end up turning it off. The important thing for you to know is that it works through the pars intermedia, which is under dopamine control, and actually will turn that off. So you get reduced POMC synthesis and reduced ACTH. So basically you're going to, in the horse, the tumors are here, remember, they only get pituitary dependent disease. You're just going to turn this off, and therefore you don't get the side effects of the excess cortisol. It is, Prasend is actually veterinary approved. So what's the story in the ferrets? We have another drug out there, and hyperadrenocorticism in ferrets is a little bit different. You see the adrenal gland, remember there's a tumor in the adrenal gland, and it's going to increase the sex steroids or the sex hormones. And these are some of the ones that you can actually measure in ferrets. I'm not sure they even do this all the time. I think a lot of times they'll recognize the clinical symptoms and they actually will treat it. And remember, trilostane or Veterol will actually get this area, but remember it's not safe to use in ferrets. So we have to think of another way around this. So we use a GnRH receptor agonist. It's called Leuprolide or Lupron. And again, these are very similar to drugs that are used for, to manage fertility in people, so they're available. It desensitizes the GnRH receptors, so if you overwhelm them with this agonist, kind of like you do with the dopamine agonist with pergolide, you actually shut them down because they're supposed to be episodically secreting. So it ends up decreasing FSH and LH, and then it turns off all the sex steroids. Okay, another one that you can use is implantable GnRH agonist. Again, as I said, these are all drugs that are used to control reproductive cycles in people, so there's a lot of different drugs that are out there, and this is another one. And it will, again, will work through the same mechanisms to stop FSH and LH. The nice thing is that you don't have to give this. You can implant it, and then you just change it every 12 months. Okay. There are some other drugs out there that have been put forward to use in hyperadrenocorticism. One is ketoconazole. There are papers that come out about this periodically, especially, I think the latest one was from like, I wanted to say Singapore, but I don't think it was Singapore. Anyway, you would only use this if you had no other option, and that means that you don't live in the United States, Canada, or Europe, and you have no drug options. You can use ketoconazole to treat hyperadrenocorticism. It's a P450 enzyme inhibitor, so most of these enzymes in here are P450 enzymes. The problem with using ketoconazole is that you end up causing liver toxicity before you ever control hyperadrenocorticism, but there are reports of people using it in areas where they can't get any of these other drugs that we can use. Deprenyl was a monoamine oxidase inhibitor which increased levels of dopamine and worked similarly to pergolide. And this came out, gosh, when I was a newly minted veterinarian. And there was a faculty member at Purdue who actually lost his career over this because there was this big hoopla of getting this out on the market. It works really well. Well, it didn't work really well. The way that they designed the studies was to sort of say, you know, is the dog feeling better or whatever? That was a big part of the study. And all the dogs felt better because it actually helped with dementia in dogs, but it doesn't control Cushing's disease because dogs don't have a pars intermedia. So it's a reason why you can't use pergolide in dogs because they don't have a pars intermedia. Okay. Any questions on hyperadrenocorticism? Yeah.
I might have just missed it. The implantable agonist, is that just for ferrets?
Yes. Yeah, the reproductive hormones that you're using to suppress the GnRH is just for ferrets because they basically show increases of sex hormones. We don't really see that in horses or dogs or cats, so we don't use those. All right. So now we're going to turn the tables, and we're going to talk about hypoadrenocorticism or Addison's disease. And I have a picture here of a Portuguese water dog. This is a really, really old picture of a 2-year-old Portuguese water dog that we diagnosed with Addison's disease when she whelped. And this is when we were first understanding that Addison's disease is so common in Portuguese water dogs because like 2 of the progenitors that came over from, that started the lines in the United States had Addison's disease or hypoadrenocorticism. So it's very inherent in the lines that are bred here. So basically what happens here is you don't have any tumors or anything. You basically just have a destruction of the cortex, okay? So you're wiping out the cortex here, okay? We think it's immune mediated because we always think things are immune mediated when we have a wipeout of an adrenal gland or any sort of an endocrine gland. If you look at pathologic samples from these guys, there will be an influx of lymphocytes and plasma cells, and the cells are destroyed. So basically something happens and you destroy all the cells in the adrenal cortex. So you don't make mineralocorticoids or glucocorticoids. So the clinical signs of Addison's, this is where Addison's becomes a problem because they call it the great pretender because it can look like a gazillion other diseases. And so it can be very, very difficult to recognize. It also means that you've got about 1 billion clinical signs that go along with Addison's disease because you're wiping out your cortisol, which has 1 million effects on the body, and you're also wiping out mineralocorticoids, which again can make it a very acute presentation. They can come in really almost flat out. So you can see acute phases of hypoadrenocorticism, and these are some of the signs that you see. One of the things that might give it away for you is that these guys come in shock, and if you're in shock, you really should have a high heart rate because you're trying to compensate for your perfusion, and these guys will be bradycardic oftentimes because their potassium is so high. So that's one of the things that might help you recognize it. But again, these guys can come in really shocky, and it can happen fast. Like it can happen in hours. We see a lot of GI signs because cortisol is important in maintaining GI integrity. So we'll see a lot of GI signs, vomiting, diarrhea, melena, abdominal pain, neurologic signs because of the changes in your electrolytes because of the mineralocorticoid problems. And here you go. How do you like this for signs of a disease, right? It can be just about anything. It can be just about anything with an Addisonian. So as I said before, it's one of those things, like we say, it's the great pretender. It tends to happen in young dogs. So there aren't a lot of young dog diseases that we think about. This is one of them. And it often gets confused with acute renal failure because it's something that would happen to a young dog. They go out and drink antifreeze, and they go into an acute renal failure. So that's what, or I'm sorry, acute kidney injury. So that's what it's confused with most commonly. All right, so we have wiped out the adrenal cortex. This is really easy. All we need to do is replace those hormones. So one of the things that we're going to replace it with is glucocorticoids, which I'm not going to talk about here because I have a whole lecture on it. So we're going to talk about how we're going to replace with mineralocorticoids. And you have 2 main options. Both of them are DOCP. So one is Percortin. It's made by Novartis, which is now Merck. And it's an injection that you give. It's incredibly safe to use. I've never overdosed a patient on this. It works really quickly. The only bad thing about Percortin is it's expensive. So this is the expensive part of treating an Addisonian. My version of this, so of course every animal's different, right, when you're treating them. And so some animals, we say that you have to give like a mg per pound or 2.2 mgs per kg IM. You can actually give it sub-Q. It's fine. It works sub-Q too. Every 25 to 30 days. But some dogs actually can wait a little bit longer, and that's helpful because it helps the owner spread it out. But if they give it every 25 to 30 days, like I said, I've never overdosed one, and they usually do fine. The other one that's on the market is Zycortal, and this is a different type of a DOCP. It's the same thing, it's just a little bit of a different formulation. Dechra produced this, came out several years after Percortin. Their big claim to fame was that you could give it subcutaneously, but actually you can give Percortin subcutaneously as well. The nice thing about Zycortal is that, and they don't have this in the product insert, but it's been published, you can give a lower dose. And this can save money because Zycortal and Procortin are about the same price. You can give a lower dose, which may save money. This works beautifully, and I'm pretty sure Zycortal is what we have in our hospital here. Again, these are just mineralocorticoids that you're giving. Can't make a hormone? Then let's give it some. This is on the same schedule. I'm sorry, I didn't write that up here. It's on the same schedule. You're going to give, like I said, you can give a little bit of a lower dose, and you're going to give it about every month. There is an oral out there as well. I want you to know it's there. It may show up on a quiz that you take at some point in your senior year. I don't know. I only have one patient that's on this or had in the last 5 years or 10 years that have been on this, and that was a pharmacist because he could get it for free. That's it. So this is an oral mineralocorticoid. It's called fludrocortisone. It is expensive, so you're not going to save any money if you put them on this, and they have to give it. They have to orally supplement it every day. I would start them off on twice a day and then transition them over to once a day. And when the injectables first came on the market, we said, okay, you know, like if we're not really sure this is an Addisonian, should we start them off on Florinef first, get them kind of regulated, and then put them on DOCP? Just go right to DOCP. It works really well, and as I said before, I've never overdosed anybody or gotten into trouble with DOCP. So again, know that it's out there, that you have an oral form that's available, that's out there, but I don't think that you're going to be using it. Okay. When you're monitoring these guys, again, we're mostly concerned about how the animal is doing. And so we're mostly concerned about the clinical signs. The expensive part of treating an Addisonian is going to be the mineralocorticoids. So you don't have to make the sodium potassium perfect. You have to get it within the normal range. So even if your sodium is low end of normal and your potassium is high end of normal, as long as the animal is doing okay and they're in the normal ranges, that's plenty. You don't have to increase your dose. You don't have to increase the frequency. Again, because this is the expensive part of treating it. Okay. We also will give them glucocorticoids to supplement the glucocorticoid activity that they're losing. Again, I have a whole lecture on this, so I didn't want to spend a whole lot of time on this. Oh, I forgot to tell you, with DOCP and Zycortal, you can use them in cats as well as dogs. We published a case report on that and using it in the cat. It works great, and you only have to give it like every 45 days. But it's a rare disease in cats, so it's not something you're going to see very often. Glucocorticoids, prednisone for dogs, prednisolone for cats, because we think they absorb it better than prednisone. And you are going to want to use a physiologic replacement dose, which is written here. And again, I will go through all this when we talk about glucocorticoids. One of the weird things about glucocorticoids is depending on the dose you use, you can get a different effect, like a replacement dose, an anti-inflammatory dose, an immunosuppressive dose, an anti-neoplastic dose, and a hypercalcemic dose. So they're different things that you get as you dose those drugs differently. That is what you need to know about glucocorticoids. And as I said before, doses usually aren't a big deal because you just look them up in a formulary, but they screw the glucocorticoid doses up all the time. Like Plums is not correct. So you actually do need to know the different glucocorticoid doses that you have to use for different situations. This is like important walk-around knowledge that you need to have. So you will be asked this time and time again when you get into clinics in front of all your friends. So it's a good thing to know. Okay, so how do we monitor these guys? We monitor by sodium-potassium ratio and clinical signs. The glucocorticoids are going to tell you, like the clinical signs are going to tell you whether they're on the right glucocorticoids. The mineralocorticoid levels you're going to learn from your sodium-potassium ratio. So pretty cheap to monitor these guys. Again, this is a totally curable disease. They do really well as long as the owners can afford the mineralocorticoids. All right. Any questions that you have? Yeah. That's exactly right. So when you're treating them, it's the monthly injection of the mineralocorticoids, and then they get the prednisolone or prednisone every day, the glucocorticoids every day. Having said that, some people will try not to give them glucocorticoids. You do need to give them glucocorticoids. They feel like crap when they don't get them. So the idea also with the DOCP when it came out was it was supposed to be a pure mineralocorticoid, and I don't think that's really true because I think there's some glucocorticoid activity in there. But they feel so much better if you just supplement them with the glucocorticoids. And sometimes if it's a stressful event, like they're traveling or something, give them a little bit more and they'll feel better. Yeah?
So, like, follow up, when we're talking about what the adrenal cortex makes, it's like glucocorticoids, mineralocorticoids, and then the sex hormone.
Right. So remember, it's salt, steroid, sex, right? Did you guys learn that in physiology? Yeah. So it's so the outer layer is the mineralocorticoids, the middle layer is the steroids, and then the sex hormones is the inner layer.
And so it's like, I mean, most of our, companion animals are going to be like spayed or neutered.
Right. So we don't worry about that.
So, like, say that they weren't like, if someone was like, oh my God, I want to breed my beautiful baby, and they weren't ever like spayed or neutered, like they're never going to be able to have, offspring if they have Addison's, unless like it was like some weird like management thing that's just too complicated. Anyone didn't care about it.
If you have an intact Addisonian or an intact cushingoid animal, oftentimes, and it's a male, their testicles are very small. Oftentimes females won't cycle. The Addisonians can absolutely have those babies if they breed early before the adrenal glands. It takes years for the adrenal glands to get totally destroyed, so they absolutely can reproduce, which is how those Portuguese water dogs got going. So they absolutely can reproduce, but one of the things we see in male dogs that are cushingoid especially is they have testicular atrophy. Yeah.
So you said that dogs with hypoadrenal and
Yeah, they call it acute kidney injury now. They keep changing names on everything, but that's what it is in AKI.
like those get confused a lot. Do you just do blood work to figure out if that's
So that's a good question. We see these cases a lot in the clinics. So an animal will be sent in, and I'll never forget, this beautiful pointer came in, and the owners were told to euthanize it because it was a young pointer, and its BO and creatinine were through the roof. The problem is that they didn't run a sodium potassium on that dog. So they thought it was an acute kidney injury and the dog had gotten into something or whatever have you. Anyway, that dog was an Addisonian, and you never want to miss an Addisonian. It is the most rewarding disease to treat because they come in looking like they're half dead, and 2 days later they're running around. The owners think you're wonderful, and they bring you baked goods. So you never want to miss one if you can, and they're so rewarding to treat. So that is one thing I've seen. So depending on what cartridges people run in their in-house machines, they may or may not run a sodium potassium. And so they may miss it. But I have seen people that have missed it even when they ran the sodium potassium. So yes, you would be able to figure it out on blood work. Yeah.
For treatment of Addison's, so you talked about doing the mineralocorticoids, like either one of those injectables, and then I know you said you're going to talk about the glucocorticoids later.
Ad nauseum. I promise.
Do you ever try to taper them off, or do they just stay at that 2-4?
Yeah, that's a good question. People do try to taper them, and I think the dogs really suffer, so I don't. They really feel crummy, and I'm not sure the reasoning behind it because we don't usually see any side effects in that. You can. Prednisolone actually can cause some side effects, and if that happens in dogs and they still need the glucocorticoid activity, you can put them on something like hydrocortisone or something else to mitigate those side effects, but give them the glucocorticoids that they need. I don't do that because I don't see why. And the dogs just feel terrible. And then they get this, what happens is they'll break with diarrhea and they just don't feel good. And then you'll put them on glucocorticoids for a while and they feel great. So I don't know if any of you guys probably don't know this, but President Kennedy, John F. Kennedy was an Addisonian, And if you look at pictures before he was diagnosed, like when he was a senator and everything, he was all thin, and they said he was like, you know, really sickly. He had a lot of spine issues and stuff. And when he got diagnosed and they ended up putting him on the glucocorticoids, you know, he really got healthy. And I just, anyway, so some people do. I just can't imagine why you would do that.
Would they be less likely to have like those negative side effects with Fred because they're not making their own?
Yeah.
So like a healthy dog, you give Fred all the time, they're going to have issues. But since they don't have any predecessor,
Absolutely right. So a normal dog's not going to make their own. The other thing is you're using a low dose. You're using a physiologic replacement dose. That is not going to fix an anti-inflammatory inflammatory disease. It's not going to fix an immune-mediated disease. So if you look at, like, we're giving 0.2 mg per kg of a prednisone equivalent. Dr. Ostel, she's treating one of those horrible immune-mediated skin things that she has to see. I mean, they're on like 2 to 3 mg per kg. It's like 10 times as much. So you've got them on baby doses. All right, thanks for listening. And I have a week off, and then I'll see you back in a week. Yay! Enjoy the morning.
Hey, quick question. If you have them on the physiologic dose, and if you needed to treat like with NSAIDs for any reason, do you have to?
Good question. That's a great question. We have used NSAIDs with these guys, even when they're on a physiologic dose of pred, but I'm terrified of that.
Okay.
So that's the time when I would put them on an omeprazole or maybe sucralfate. Or the other thing that you could use is misoprostol, because that's actually a, yeah, you wouldn't, you know what, it's the morning after pill actually, believe it or not. Yeah, it is. But it's basically an antiprostaglandin drug, and so it will help with NSAID toxicity in the gut. But I'll tell you what, I will do it if I have to, because you get the Addisonians that then get arthritis, and what are you going to do? And so I've done it, but you have to be really careful with those dogs.
Okay, so just avoid at all costs.
If you can,
Okay.
yeah.
Okay, great. Thank you.
I'm sorry.
Hey, no.
Okay, so ACTH skin test to
Yeah.
monitor the treatment of hyper. Why would you expect the results to come back normal?
They wouldn't. You don't want them to be normal. You want them to be suppressed. And Dr. Bugby will go through this with you. I absolutely promise. I'll try to do a case example if I have time. But you don't want them to. You want them to be suppressed. So you want a flat line. You want the pre to be like 2 and the post to be 2. Whereas in a normal animal, you want your pre to be like 2 and your post to be like 15.
Okay.
So you don't want it to be normal.
And so you want it to be lower because you want to prove that your drug is actually suppressing.
Exactly.
Okay, just needed to make sure I understood that.
Yep, you got
Okay,
it.
thank you so much.
Yeah, of course.
I just wanted to say thank you because you're amazing and
Oh,
you brought light to
thank
my
you.
day and
Thanks for
you
saying
gave
that.
me the will to continue.
Oh,
So thank you.
Oh my gosh, this is the
If
worst
you could
year.
teach everything, that would be great.
This is your worst year.
It's rough.
It sucks.
It's real didactic. Like there's
Yeah.
like no animals.
No,
it's,
and not only
like,
that,
sit
but
across from the
I was
lab.
sitting back there. I'm going, how do they pay attention? I could never do this. I could never do this again.
It's
Like, I don't know how you just sit there and listen all day. I'd have to kill myself.
well, you make it interesting to listen. And
Well,
you
good,
make it
I'm
very
glad.
clinically relevant, which I appreciate because you give me the why do I care, and it's like that's why I care.
Yeah, this is why
That's
you care.
exactly why I care.
Yeah,
So,
good.
I
I'm glad.
appreciate
I'm glad.
I was a little confused about
Yeah.
sodium potassium. So if you're thinking it's acute renal injury, and then you do electrolyte panel, how is it going to look different?
So